Thank you. Well, today I'd like to introduce Aparna Seth, who is a fourth year implementation science PhD student. She is originally from India and already has two prior master's degrees, one in development and environmental management and one in health and health policy. And I actually just learned this year that she has a bachelor's in biotechnology. So she's very diverse in her background. She's also worked at several reproductive health organizations and for local institutions in this space of reproductive health, including at the Bill and Melinda Gates Foundations and for Exemplars in Global Health with Gates Ventures. And today she's going to be presenting on her dissertation project, which I'll let her tell you about. It's a work in progress today, but we're happy to have Aparna here to talk about where she is in developing this project. So thanks, Aparna.
Thanks, Alison. Just quickly go over the agenda for the talk today. Just talk about the our research team collaboration. Then we'll go over the study background and aims. I'll spend most of my time talking about the methodology, which includes three components. One is a literature review, then qualitative research, including in-depth interviews with women in Kenya, and finally with the scale that we are developing, evaluation for that, talk about the timeline for the project, and then spend some time on discussion. I have about 30 or so slides, so feel free to stop me at any time if there are any questions. I'll keep looking at the chat as well, but feel free to interject if there's anything you would like to ask or share any feedback on. So this is our research team. This project is being implemented by a consortium here at UW, led by Alison, who's the PI. And then you can see some students who are working from WACh on this study, as well as Kelly. Then we have folks joining from Kenyatta National Hospital, including Dr. John Kinuthia, who's the co-PI, and then some other staff. I won't name their names. They are here on the slide, and I know Agnes has joined. Agnes, so nice to see you here. I know it's very late at your end. And finally, we have Dr. Jenunger, who's also the co-PI from Women and Infants Hospital at Brown University. This research is funded by the Gates Foundation, as well as some funding from a UW Royalty Research Fund. Should mention this was Alison's idea, brain, that she was exploring funding from when I had joined the program. So I'm really grateful to her for including me on this very interesting research project. Before I dive into what exactly we are doing in this research, I would first like to just start by defining what I mean by fertility intentions here, given the focus of this grant to explore how to better measure fertility intentions among women. So simple definition for fertility intentions is basically it includes thoughts, feelings, desires that people might have about having any future children, includes whether they don't want to have any children or not. This is generally measured retrospectively or prospectively. What do I mean by that? Retrospective assessment is for a pregnancy that has already occurred. Does not depend whether that resulted in a birth or not. It's just anchored on the most recent pregnancy. And generally, it is used to calculate unintended pregnancy rates at the population level, which includes a combination of mistimed pregnancies, that is, pregnancies that happened at a time which was considered sooner by the respondent, or unwanted pregnancies, which are pregnancies that were not wanted at all at any time by the respondent. Since these are population level measurements, generally the data sources include DHS or the Demographic and Health Surveys, MICS, PMA, which is like a very specific family planning, reproductive health survey conducted in select settings, NSFG, which is a US specific survey. Plus, there are some other new scales that have been introduced for retrospective assessment, including the London Measure for Unplanned Pregnancy. Now, the major issue with retrospective assessment of fertility intentions is that it is subject to bias, because we are talking about a pregnancy that has already happened. So women might adjust their feelings once they already have a child. They might think of that as an intended pregnancy, or might change their feelings about that. The second way to measure intentions is a prospective assessment, which is basically before a woman gets pregnant. And this is generally done or considered important to inform reproductive health service delivery. For instance, identifying need for contraception advice, or counseling, preconception care, or even both. There has been a lot of development in this field of prospective assessment of intentions, and we've seen a lot of psychometrically validated measures that have come up. For example, the desire to avoid pregnancy, or the DAP scale. However, I will mention that there has been little population level research when it comes to prospective assessment of intentions. Now, quickly going over this specific study that we are doing. As I mentioned previously, fertility intentions, the assessment of intentions is critical for providing appropriate reproductive counseling to women and girls, and also to monitor success of family planning programs. For this specific study, we are focusing on assessment of current fertility intentions or prospective fertility intentions. The examples that I was sharing previously, for instance, the desire to avoid pregnancy scale that has been developed to prospectively measure intentions, and other examples as well. We encountered several challenges with such measurement approaches that exist for prospective measurement. For instance, these existing measures, they do not allow for spectrum of feelings that women can have about a pregnancy, including ambivalence or uncertainty, like maybe they are not sure, or they've not made a plan whether they want to have a pregnancy or not. There are very limited prospective measures currently, and most importantly, none of them have been developed in an LMIC context. All the existing ones like DAP or some others that I'll talk about in the subsequent slides, they have been developed mostly in the US settings. And another important thing that I want to flag here is that none of these existing measures have been designed for measuring fertility intentions among adolescents and young girls. So through this study, our main goal is to develop a locally derived, very comprehensive scale so we can measure prospective fertility intentions among women and girls. And in this case, we are doing this study so in Kenya, so specifically looking at that setting. Now, to give you an overview about the study aims and methodology. The first aim for our study is to identify existing measures of fertility intentions, including identifying any merits, gaps, and limitations, and developing recommendations to draft a new scale. The approach here is to conduct a systematic review, which we did last year during summer, followed by expert consultations in the field of family planning and reproductive health. Again, this happened in the fall of last year. Our second aim is to refine and pilot the new psychometric survey. And here our approach is once we have the draft psychometric survey, we are doing in-depth interviews with women to get feedback from them on the scale items. as well as assessing acceptability and appropriateness of a scale like this to be embedded in their reproductive health counseling when they visit providers. Following that, we intend to revise the scale and then administer it to women. This will be a quantitative survey, and we will basically do some scale evaluation at this stage. And next, we are hoping our validated scale that is developed as part of AIM2 can be embedded in an existing reproductive health project that Alison is leading, and we can conduct an external scale evaluation through that step. This is just a graphic of all the steps I just mentioned, and I'll basically go over each of these aims in detail now, starting with the aim 1. As I just mentioned, this includes starting with the systematic review. So we basically developed a PubMed search strategy to identify studies that have been conducted to measure fertility intentions. And our initial screening resulted in about 512 studies, and when we did the abstract and title reviews, we were down to 99 studies. Further, we ended up excluding 42 of those because either they did not include any scale or survey to assess intentions, or they just had like a general assessment, do you want to have a child in future, and no more details like that. We ended up having about 57 studies that resulted in about 12 different scales or surveys that have been used to measure fertility intentions. Not going into details on each of those, but starting with the snapshot here on the left, there is a scale called London Measure of Unplanned Pregnancy, followed by the Desire to Avoid Pregnancy scale, which is on the left bottom corner. In the middle, there another survey that exists, which is One Key Question. On the bottom in the middle is there are examples of surveys that include questions on assessing fertility intentions from DHS, mix, etc. And last example on the right, which is attitude towards potential pregnancy scale. So examples like these that measure fertility intentions either through surveys or psychometrically validated scales. Based on our review of all of these measures, we ended up with 8 specific constructs that are outlined here on this slide. Might actually go to the next one to give you an overview of those very quickly. So the first one is childbearing preferences. This construct is generally employed in surveys to assess whether a woman wants to have a child in future or not. And this is basically considered a direct measure. An example survey questions are, would you like to have another child? If yes, how long do you want to wait before the birth of that child? So asking a woman very directly about their intentions for a child in future. The second construct is on cognitive desires and preferences, and this is an indirect measure of similar things, whether the woman wants to have a child in future or not, and assessing their thoughts and beliefs and aspirations regarding that future pregnancy. And some examples from existing surveys here include, if I had a baby in the next year, it would be a positive addition to my life, or if I had a baby in the next year, it would be end of the world for me. The third construct that we identified was around feelings and attitudes about future pregnancy. Now, this is slightly different from number 2, which is more about cognitive desires. So some example questions that we identified on this construct were, how happy would you be if you became pregnant now? Or how worried would you be if you became pregnant now? Going on to the fourth construct, this was around assessing strength or certainty of the stated fertility preferences. For instance, asking questions such as how important is it to you to avoid becoming pregnant now, or how certain are you whether you want to become pregnant or not. The fifth construct was around stability of these fertility preferences by asking questions such as how likely is it that you would change your mind regarding whether or not you want to have a child, or change your mind about the timing of when you want to have that child or not. Going on to the sixth construct around anticipated consequences of the pregnancy, or implications or perceived outcomes because of a future pregnancy. So for instance, asking questions such as, if I become pregnant now, it would be hard for me to manage raising the child, or if I become pregnant now, I would be concerned about the effects of that on my own health. The final two constructs that we identified were around pregnancy planning or preparations that one would do for getting pregnant. And this was mainly focused on spousal communication and aligning on fertility desires with the partner. So for instance, asking questions such as, my partner would support me if I wanted to use a method to prevent pregnancy, or my partner would support me if I wanted to become pregnant. So both cases, whether they want to avoid a pregnancy or whether they would like to become pregnant. And finally, the last construct around ideal number of children. So this typically measures an average desired family size. So an example question here, this is from DHS, is they ask people generally do not have exactly the same number of children they want to have, and if the person could choose exactly the number of children they wanted, how many children would they want to have? So these were the 8 constructs that we synthesized based on our systematic review. And we took all of these constructs to an expert panel and reviewed each of them along with some suggested survey items. So this slide basically is highlighting who all were included in the expert panel consultations. This is broken down into 2 parts. The first part it was a group setting, basically, with all these experts joining, followed by one-on-one consultation that we had with Dr. Bukusi and Dr. Nelly Mugo to review these constructs and survey items. You'll notice most of these experts are from East Africa or have experience working in East Africa, and we were trying to have some gender balance and ensuring that we were getting inputs from clinicians, researchers who have worked in this domain of family planning research and fertility research in Kenya or East Africa in general. Plus, I will also mention, since this scale also has a component around adolescents, so we were also trying to get inputs from these experts on adolescent-specific considerations on these scale items. Very quickly, I'll mention some of the feedback that we got from our expert panel consultations, starting with the one on the left. One thing that our panelists advised was to have enough scale items that are worded positively or negatively. For instance, if I become pregnant now, it would be bad for my life, which would be considered a negatively worded scale item, compared to if I have a pregnancy now, it would be a positive addition to my life, which would be a positively worded scale item. So they recommended we have enough of those mixed wordings because there is a chance that the positives and the negatives might not load on the same scale when we do our factor analysis. Second feedback that we received from our experts was around the timing that we are using to assess fertility intentions. And as we were reviewing literature, there were examples where people were asking about intentions in the next 3 months, 6 months, 1 year. And the feedback from our experts was to focus on now or current state at this moment, because fertility intentions can change over time, and as personal situations might change for women, they are not stable and they would change. Related to this, I will actually go to this point on the right in the middle around stability of preferences. So if you may recall, this was one of our constructs identifying whether intentions are stable over time or not. And our panelists recommended that we drop this construct again because of the same reason, that intentions are subject to change with time, and more importantly, it does not even capture ambivalence because of that duration. So we ended up dropping that construct from our assessment. Another thing around adolescents was the feedback that we got was to consider adaptations for some of the scale items for adolescents specifically, because they might not be actively planning pregnancy, and it would also depend on their relationship status. So that is something to consider as we are doing this assessment on fertility intentions. Now, I'm again going to the left-hand side of this slide. Sorry for all this confusing back and forth here, but the left middle feedback that we got from our experts was thinking about pregnancy avoidance versus pregnancy acceptance, and be balanced in asking about both of these concepts in our scale items, as that would also include ambivalence in some sense. And finally, this was an interesting thing that came up as we were reviewing the existing scale items. Some existing measures were asking about pregnancy. So if I become pregnant now, so they were worded like that. And some other survey questions were asking about baby, for instance, if you had a baby in the next year. So there was some discussion about checking if we need to have both type of wording or focusing on one. For instance, one specific feedback that we received was maybe adolescents might resonate more with the language around pregnancy, and it is possible that older women might like the wording around having a baby as more preferable. So based on this feedback, we ended up narrowing our draft psychometric survey on these 5 constructs included here in the middle. So cognitive desires and preferences, affective feelings and attitude, strength, anticipated consequences, and number 7 on agency. This was we were initially considering this as pregnancy planning, but from our expert panel discussion, we had some discussions that the concept of planning might not really apply in the Kenyan setting, and most of the questions that we were looking at under that construct focused on spousal communication and getting to some concepts around agency actually, so we ended up rewording this to agency. Final thing I want to mention here is after the expert panel discussions and in process of developing our draft psychometric survey, we also reviewed literature on some existing conceptual frameworks that could inform the design of this survey. And there were several interesting theories that exist, for instance, the health belief model or TPB, etc. But based on our review, we decided to anchor on this conceptual framework included here on the right-hand side of this slide, focusing on pregnancy acceptability by Eichen, Caligari, and Dellendorf. The main reason for anchoring on this framework is basically this framework. If you look at the middle, sorry, at the end, actually in the bottommost box, this sort of focuses on pregnancy acceptability, like having a pregnancy or not, considering it as acceptable or not. Also focuses on contraceptive use, which could be related to the concept of pregnancy avoidance. So in a nutshell, this we felt that this framework actually goes or expands this idea of intentions to wantedness and acceptability of the pregnancy. And as the authors were describing in this framework, it focuses on factors such as personal circumstances, the social and cultural norms in which settings these women are living, their individual beliefs about pregnancy, motherhood, and abortion. So sort of a broader framework, and that was a broader pregnancy acceptability framework, and that is why we decided to anchor on this for selecting scale items and developing the psychometric survey. Coming on to aim 2, which includes our in-depth interview. So we are conducting 40 IDIs in Kenya, in 2 regions, Nairobi and Western, in the Kisumu County. And there are 4 main objectives of these IDIs. Primary one is to assess any gaps, irrelevant or redundant or unclear survey items that we have in our draft right now, getting feedback on the wording, including the translations that we have. For instance, as I flagged earlier, the items that are worded positively versus negatively, items that have pregnancy versus baby phrasing. The third objective, getting feedback on the scale format or labels. For instance, we are using Likert scale options, so just making sure that those options are clear or if any rewording is needed there. And finally, assessing the acceptability and appropriateness of the scale to inform provider counseling in a clinical setting. The right-hand side on this slide includes disaggregation of these 40 IDIs. So we are disaggregating by age groups between 15 to 45 years and by parity. So including women with a prior pregnancy or not. Eligibility criteria includes age between 14 to 45, as I said before, currently not pregnant or sterilized, because we are not interested in any retrospective assessment of intentions and looking at prospective intentions. Sexually active within the last 12 months and can speak one of these 3 languages, which are the main spoken languages in these Kenyan settings. I'll quickly walk you through some of the preliminary IDI results that we are seeing. So far, we've conducted 30 out of the 40 IDIs, and we are in process of developing our analyzing this data in Atlas TI. We just finalized our code book last week. So under cognitive desires, which is our
I think you're muted. There you go.
Yeah. Okay, so the first construct around cognitive desires, these are the sample questions that we have here. Under this construct that we've received a ton of useful feedback from our participants. Most of the scale items, most participants thought that these scale items were relevant. And they thought that having the provider ask them these questions around fertility intentions was important to inform their counseling experience. They also, participants who were actually actively wanting to get pregnant were most likely to find scale items on wanting the pregnancy or having it be a positive addition to their life as more important, while women who did not want to become pregnant soon, they did not find such scale items important or relevant, which is expected. Participants also shared that response options for some of these scale items, for instance, for the second one, how much of a problem would it be? We had response options such as small problem and big problem. These were difficult to understand and quantify, so they recommended simplifying it. And finally, extreme statements that sort of stigmatized pregnancy, they were not considered favorable by almost all of the participants that we have spoken with so far, regardless of their pregnancy history. So for instance, the one at the end, on the end of this slide, with the wording "end of the world," that did not resonate with any of our participants, and they thought it was too extreme. Some people mentioned whether, it seems like becoming pregnant is sinful, or it implies that one should consider suicide if they became pregnant. The second construct was around affective feelings, and these are the 7 survey questions we had on which we are getting feedback. Some initial feedback that we have received is the third and the fourth questions here, how worried you would be and how upset you would be if you became pregnant now. They are very similar, and there was a recommendation to consider only one. Some people felt that the word upset was unclear, so that was the one that was recommended to be dropped. Then the fifth question here on this slide, when I think about becoming pregnant, I have mixed positive and negative feelings. This was considered unclear and hard to understand. Like, what did we mean by mixed positive and mixed negative feelings? So there was a recommendation to simplify this. And finally, our last survey question here, which was around thinking about becoming pregnant makes me feel stressed out. The wording was considered confusing, and the recommendation was to simplify it by just saying that becoming pregnant is stressful. Our third construct around strength of preferences, we only had 2 questions here, and the wording of those questions were reported to be clear. However, our participants mentioned that the response options that we have for these 2 survey questions, they were a little difficult to understand. For instance, we had middle categories like somewhat important, somewhat unimportant, and somewhat certain, somewhat uncertain. So the recommendation was to simplify those Likert scale options. Our fourth construct around consequences of pregnancy, this was the one where there was no feedback in terms of changing the question or the response options, and our participants mentioned that these were clear and important to be included. And here we are focusing on 3 aspects in terms of consequences of future pregnancy around managing, raising the child, which could include financial aspects or other family aspects. The second one around achieving other things in life, so whether it is about education or employment, and the final around health effects for that woman. And our final construct, which we relabeled as agency, this was also perceived as important by most of our participants, and they thought that asking about women and their partner, whether they align on their fertility intentions and pregnancy desires, was important. However, there was some feedback on this phrasing around who has the most say. This was considered difficult to understand, and the recommendation was to ask directly who basically decides whether you want to use a method to prevent a pregnancy or not, or who decides about when you would want to become pregnant in your life or not. There were some other feedback around the question versus statement format, given we had scale items that were worded as questions as well as statements. And just try to find, yeah, we have some example here, like the first 2 examples are about questions, and the next three are statements. And our participants thought that the question format was easier for them to understand, and the statement format sort of seemed more like a directive and less space for them to actually think about and give responses to. So they thought it would be better if our scale included scale items worded as questions. And finally, on this baby versus pregnancy phrasing, most of our participants felt that baby phrasing was better and it implied personhood, as some pregnancies could end up in miscarriage and abortion. So it's difficult for someone to actually think about pregnancy and then respond. And it is also possible that a pregnancy wording might offend some people, as maybe they cannot get pregnant, but they can still have a baby through adoption or other ways. Ultimately, baby phrasing wording would be more inclusive. Now once we finish all of our 40 IDIs and analyze all of this feedback, our goal is to finalize these scale items across these 5 constructs and then administer them to 100 women in the same 2 settings. We are also exploring if we can increase the sample size to maybe 300 or 400, depending on budget considerations. Obviously, our plan is to conduct exploratory factor analysis once we get this quantitative data for scale finalization, and mainly it will include item reduction and dropping items that are not relevant or internally consistent in the scale. Right now, we are at 23 items, which is a lot, and we want a scale that is concise and comprehensive. So that will be our target. And finally, coming to our last aim around scale evaluation. So once we have results from our EFA, we would again go back to our scale and revise it and drop the items that are not relevant, and then embed them in our existing trial that Alison is leading, and then conduct confirmatory factor analysis on that sample. As I said previously, this is where we are currently on the qualitative research stage. And once we have those results, we'll launch our scale pilot round 1, and then followed by scale evaluation. That was my last slide, and I'll stop here. That was a lot of me talking. So I'll pause and see if there are any questions or recommendations on the items that we have currently, any feedback on the wording, or any suggestions on how, the analysis approach that we should consider. I will mention that I'm very new to this EFA, CFA world and still reading about it. So yeah, please let us know if there are any suggestions for us there.
Thanks, Aparna. As people are like thinking about potential questions, I'll just ask you one, which is, we have this division between like the adolescents and the adults, and just based on what you've heard like so far, what do you think the divisions are? And like, do you think that we'll end up with like 2 completely separate scales? Will there be a lot of overlap, or what are you seeing initially based on the transcripts that you've read and the debriefing with the teams about like the differences in how these fertility intentions are perceived for adolescents versus adults?
Yeah, I don't anticipate the scale to be very different based on what I have heard so far from the debrief sessions. 2 things that have come up. I'll mention those. Adolescents are sort of preferring the scale items that are negatively worded, maybe because they don't want to have a pregnancy very soon. So they think those should be included, versus some of the feedback that we have received from older women is pregnancy or having a baby, that's a blessing, and we should not be having any scale items that are negatively worded. So that is one differentiation that we are hearing. However, even for adolescents, although they prefer having scale items that are negatively worded, they also don't like any extreme negatively worded statements such as end of the world. Even for them, that is very extreme. And the feedback that we have heard so far is fine, that is not desired, but if it happens, they will make it work.
Were you surprised by the number of questions that people gave feedback about not understanding kind of the question or the language that was used? And do you think it was maybe like a language barrier thing that they understand it, or what are your thoughts on that?
I was surprised. I was very surprised. I thought, I mean, I agree. One of the limitations of these existing surveys is they have been developed in the US setting and never sort of piloted or validated in low and middle income settings. So, but I was not expecting feedback on wording like as small as, for instance, what do we mean by upset? Or what do we mean by stress? And it is not about comprehension. It's just that that is not the local or usual way that they talk about that concept in general. So the feedback was to simplify it or use words that are used in their general use versus some of these very American versions.
Interesting. Thank you. Sarah, if you want to go ahead and ask your question.
Thanks so much for the presentation. Really well done. I think it's very clear. I like the way that you've presented, and your slides are really clear. I wasn't surprised about that, because I do know in our culture, it's not, we don't talk about stress or things that are very negative a lot of times. People are mostly positive. So I wasn't surprised. In fact, I was expecting that. There was one question which you put there about if I got pregnant, that would be the end of life. If that was in a survey, that I think would not be acceptable to people, because it's not, I don't think it's that, like, to that extent that it matters to that extent. To some it does, but I think that was like to the so much on the other extent. But my question was, in terms of the skills that you are thinking about, it looked, unless maybe I didn't get it well, it looks like it's either a yes or no kind of thing. Is there a skill? Do you find that there are people who are in between there, or did you just want to use it's there or not, so that you're able to understand? I could have missed if I did.
Yeah, I actually did not include the response options here for space, but we are using Likert scale options for all of these test questions that we have right now. So for instance, like this one, thinking about becoming pregnant makes me feel excited. So this is a strongly disagree to strongly agree scale. And another example is how happy you would be. So this is again like very happy, somewhat happy, and that was the feedback we got, like what does somewhat happy means or somewhat unhappy means, and how do you quantify happiness? So all of these test questions have a Likert scale option, and we are getting like very rich feedback on even on those things.
Thanks. I think that would be really nice, because you can now see where people are at. And also it avoids the issues about the negative versus positive, because people will automatically sort themselves in one of those. Yeah, thank you so much.
Yeah, and to your first point about the end of the world statement, yeah, initially our hypothesis was maybe that would be a good one to include maybe for adolescents who don't want to become pregnant right now, don't have any plans for pregnancy soon, but yeah, this did not, I mean, even they did not like it, so we are considering dropping it.
Yeah, I think you could rephrase it rather than, even if it's, I think the issue about it would be the end of life. I think we don't tell the adolescents that if you got pregnant, it would be the end of life. I think
Yeah.
it would have consequences, and I think that's what they're afraid of. I'll have to drop out of school. My mother might kick me out. I might not be accepted. I might have to get an abortion. Those are the things that they fear, but I don't think they think about, end of the world for me.
Yeah, agreed. Agnes also put this in the chat. She's very closely involved in some of this qualitative data analysis, and she also flagged that usually, even if unintended, culturally, babies or pregnancies are not viewed in extreme negative.
I mean, I think there's a couple things with this project that are kind of illuminating beyond just the fertility desires. I mean, one of them is just the process to go through this. So, we did start with like the panel that we started with and initially vetted this. And granted, we're looking at a lot of questions initially. And so this is a pared down list from the initial version and trying to get more general feedback. But some of these things that are coming out so clearly in the interviews, like we also probed with a lot of, East Africans and Kenyans specifically, and those weren't flagged as like bad at the time. So I think it just highlights that the process, does work to have, multiple steps, like the expert panel isn't sufficient. You still have to test it. And then the other one is really broader beyond the scope of this project, but we use Likert scales all the time and other things. And it's really been surprising how much people like are not responding to that. And so, we started this project with this idea of, fertility intentions are very cultural and that, there are some validated scales out there. Some of them are tested in different contexts and settings and including in LMICs or, in the global South. However, they don't ever tell you what you're not capturing. And so trying to apply a scale, I always think about the PHQ-9 when I think about this. If you're measuring depression and you're using the scale that was like developed and validated in like the West, and then you're applying it in the global South, like you can go through the process and validate it, but are you missing key critical constructs that like were never included in that scale that like would make you misclassify people, or you're just missing something so big? And so we started from that lens of like maybe there's a lot that's missing. And with the Likert scale though, it's just been so surprising me how this like the somewhat happy, like what is somewhat happy? And now I'm forgetting what maybe with something that's frequency related, like a Likert scale that's frequency related, like the PHQ-9 where it's like, how often do you have difficulty concentrating, like some of the time, most of the time, all of the time, and then with specific parameters around like that's how many days, is in the key. So maybe a Likert scale that's like very clear like that, but something that's more subjective about feelings is just not performing well, like somewhat happy. And so I think where we're likely leaning is like more of like 3 categories, or wait, what's the other one? Aparna, I can't remember now. Like, what was the suggested revision?
Was to drop the word somewhat and just say happy,
Yeah.
very happy, happy, unhappy.
Yeah, that's right. So
very
it's like
unhappy. Yeah.
it's like very happy versus happy. So you still end up with, 5 categories, but you're like trying to add like a extra word to the extremes instead of an extra word to like the middle-ish categories that are not neutral. So I don't know, it just makes me think a little bit more about like the other scales that we use that are quote validated and what a lot of those limitations are. And it's just been like a great project to learn more about like psychometric scale development. Aparna and I are learning. I mean, she knows way more than I do about this, but we are learning together how this all works. And we're getting a lot of different guidance depending on who we ask, which is why we're like, oh, someone else said we should increase the sample size. So just sort of highlighting that even when you consult the experts, that sometimes, the experts might have disagreements about like the methodology and the best process. So we're trying to like take that and learn from it.
I totally agree. I think I was actually going to say if you use the 3, it's much easier cognitively for somebody to answer 3 versus answering 5. And because we don't do that a lot, because even in the education system and the way that it is structured, we don't do Likert scales like they do here. So it's like you're telling them to choose between so much. And I think in the US, it's like there's always all these many options. Here it's like, okay, just help me with 3. And I think that would be either that I'm not or I am, and I'm in the middle. That usually is really helpful. And most of the time people will go towards the happier sides. You will notice that.
It's really interesting because I feel like the American perspective, and maybe I'm like too biased in this, is like people are unsatisfied if it's like, well, I'm not happy and I'm not unhappy, but I'm not neutral. Like that there's something satisfying about having more options. I mean, then you can get to like the scales too. I know, I'm not sure if Brandon's still on, but the idea of like the slider from like a 0 to 10 or 0 to 100, and then you're kind of like, sort of arbitrary, whereas like, is there really a difference between 86 and 85 and 87? Like people are just kind of generally, and they end up in like some bucket. And whether that's more satisfying on a scale of 0 to 10, like how happy are you? And then that like you get more precision and like, well, I can really slide that scale, what feels comfortable for me, that's more precise, instead of really trying to lead people into like, because ultimately when we analyze it, I mean, we have this with like contraceptive satisfaction data too. It's like really you end up kind of lumping the satisfied and the very satisfied anyway, because you just kind of lose power without it. I mean, obviously it depends on the size of your project, but you just like don't end up with a lot of people who who are kind of in the middle anyway. So the extremes are actually more important, or potentially like if the extremes are really indicative, and then the middle people, if they were to slide more toward the middle, like that might actually be the deciding factor of like, well, are people really satisfied? Or are they really happy? It's like if they can identify the extreme, that's what matters. And then the middle should be lumped more in the middle. But whether people would say that or not, I don't know. I feel like there's probably like a whole science on this.
Yeah. I think in our case, even that middle is very, very important, because for us, those are the people who are not sure and who have not made any plans. Really, for instance, how much of a problem would it be? Like, I don't know. I am not sure. So even like for this case specifically, even that middle is critical.
Even the question you had about you'd have the mixed positive and like the mixed negative feelings, trying to capture both of them. But then again, there was some feedback that they didn't understand that. But I see what you were trying to do there, where it's like you may have some positive, you may have some negative. So how do you capture?
It was interesting. There, the feedback was, if you say mixed feelings, that captures, positive, negative, or whatever. So the recommendation was to just simplify it to say mixed feelings rather than, specifying the direction of those feelings.
You also learn how like important the language matters when you're like asking these questions. Like we've had discussions about like ambivalence versus indifference. So the difference, well, I'll let Aparna say, like, what's the difference between ambivalence and indifference?
Indifference is, according to what I read at the middle, like I'm not sure, I have not made any plans, and ambivalence is conflicting feelings. So maybe I want to become pregnant now, but on some other scale item, I would say something completely opposite. Because in reality, what my situation is, that might influence what to do with that baby eventually. So ambivalence is like mixed feelings, as we were discussing earlier. And indifference was not sure, not made any plans.
Yeah, they seem like they're the same, but then when you like dive deep, you're like, oh, they're actually different. Like I might feel one way today and tomorrow a different way, and that's more of the mixed feelings or ambivalence, and it's not the same. But if you were to like analyze it, you could end up with like the same kind of neutral answer, but they're actually not the same.
Yeah.
So
Yeah, that's hard. That's hard to quantify and define.
I mean, and then you add like 3 languages in here, and then like it's even more complicated because, you know, different languages and the terms you use, like they might work in one language, but then not another. And so trying to find the appropriate words for each. I mean, we're testing them in different languages, but
Oh, wow. Oh, well, we might have to have you present again, Aparna, you know, after you kind of change the questions, because now, you know, it's really fascinating.
Yeah. Would love to give an update on where we land, maybe in July or August.
Yeah, next year. Yeah, that would be great. Awesome. Well, we are at time. So thank you so much, everyone, for joining. Thank you for presenting, Aparna. And yeah, great job on your presentation. You did an amazing job. And yeah, the visuals and the flow and everything was great.
Thank you, Alison. I'll get feedback from you next week.
that was great. Great job.
All right.
Okay.
Thanks, everyone.
Bye.
Bye.
Bye.